I'm going to talk about fertility and fertility issues in neurology. This is just a kind of summary of the spectrum of fertility issues that I have read about or encountered in neurology and that we might come across. So first of all, conditions that affect fertility, and things that came to my mind immediately were autonomic dysfunction, where there is likely recovery, for example, in GBS, but also autonomic dysfunction in degenerative conditions as well. And then also, obviously, there's a lot of conditions in neurology that are, affect physical function and would provide a barrier to conception. And then things that we come across maybe more routinely on a day-to-day basis are medications and medications that either are teratogenic, and I'm sure, well, I think Amber might come on to this. Routine medications, I've kind of called this medications that we use on a daily basis for very common conditions such as headache and epilepsy, and where we do need to be very mindful of the risk of teratogenicity and inform or make sure that patients are adequately informed about choices. Disease modifying agents, and the thing that came to mind with this was disease modifying treatments for multiple sclerosis, which either affect fertility or are teratogenic and require patients either to avoid conception or to delay. And fertility preservation, which something I'll come back to, and this is in the context of certain chemotherapy agents that we use in neurology. And finally, there's the factor of fertility with regards to inherited conditions in neurology, which is very common. And there are various options for these where we might need to involve our colleagues in obstetrics and gynecology, and that would be for counselling and potentially for amniocentesis to check for certain conditions. And increasingly, there's also a role for pre-implantation genetic diagnosis. And I'll maybe come back to this in another 135, because this is obviously something which is quite relevant to motor neuron disease and something that I'm particularly interested in. So what I'm going to focus on today, next slide, Amber, sorry, is the fertility preservation. So the main example of this is with the drug cyclophosphamide. And handily, there's a really useful practical neurology paper which I've referenced, which outlines the requirements for this. So this is a drug that prevents DNA synthesis and RNA transcription. So it affects rapidly dividing cells, which means that it's useful for targeting things like vasculitis, but it also affects oocytes and spermatogenesis as well. So as I said, it's used in CNS vasculitis, autoimmune encephalitis, Tay-Sachs, myositis, and there are other examples. And it has various effects on fertility, and it's dependent on the patient's age and the dose of drug used. In males, it can cause infertility in 20% of postpubertal males receiving low-dose treatment, but that's really up to almost 100% in those receiving high-dose treatment. And in females, there's estimated ovarian failure in 50% of those over 32, and that's based on studies in lupus. And also premature menopause is very likely. And this is just a picture that I've taken as a screenshot from the form that that we can access from the assisted conception service at Glasgow Royal, if we do wish to refer someone for fertility preservation in preparation for cyclophosphamide. And I've highlighted the reasons that we would indicate on this form. So in these neurological conditions, it would be a non-cancer medical reason, usually in the context of chemotherapy for cyclophosphamide, and with the predicted reduction in fertility after treatment being between 20 and 100%. Next slide. And the process involved in this is obviously different for males and females. In advance, we have to make sure that the patient has capacity to consent to the treatment and to undergo the procedure. And some similar requirements for any fertility procedure such as IVF, where females need to be 37 or less, or under, sorry, and males 55 or under, and females need to have a BMI of less than 35. And in this case, we kind of have to provide evidence that the treatment is with intention to cure, so that we're preserving fertility for future family planning. And this is a flowchart that I've taken from the Practical Neurology paper, which highlights the different pathways for males and females. For females, and I'm just obviously highlighting the postpubertal pathways, it's a lot more complicated. And in particular, the timelines are actually quite long. So there's potentially 2 to 3 weeks to undergo the storage and preservation of oocytes or embryos, which has a significant impact on the planning of treatment as well, because usually in the case where we need to use cyclophosphamide, we need to do it as soon as possible. Whereas in males, it's a lot more straightforward with the preservation of sperm samples, which only takes a couple of days. As with other IVF treatments, embryo storage and preservation is a lot more successful than oocyte storage, because the oocytes are more susceptible to freezing and damage from freezing. And then the other factors that we have to consider is that there's obviously a risk of failure, so that an individual might go through this process but still not be able to conceive later. And I think from our perspective, in females, there's a risk of ovarian hyperstimulation syndrome, which can cause patients to experience intra-abdominal edema, but can also, in rare cases, lead to thromboembolism and renal failure. So this also might have a significant impact on treatment plans and delay treatment. So a lot of factors to consider, and I think essentially we would take a lot of advice from our colleagues in gynecology. Thank you very much.